The Fact Check podcast is hosted by three rehab professionals with decades of combined experience. But I'm not one of them. I'm just making this intro. If you are finding the world of health and musculoskeletal care confusing and contradicting, and let's be honest, at times a bit crazy, our efforts here are aimed against all that misinformation through real research and real evidence. Let's do this, people. Nothing you hear on this podcast should be considered medical advice.
Hi, everyone. Welcome to the Fact Check podcast. I'm your host, Alexis, Léveillé, and I'm with the co-host. Can you introduce yourself?
Hidalgo.
Yeah. So I'm coming from Montreal. I'm a physical therapist and I also do some injury consulting remotely all across the world, but my main practice is in Montreal. Diego, where are you coming from?
I'm coming from Madrid. Currently, I'm working at a hospital setting, mainly dealing with orthopedic and sport injuries.
Yeah. Since it's your main episode on this, can you give us a little bit of an intro? So I think you used to be a journalist before, right?
Yes, indeed. I chose to become a journalist like in 2019. I finished my degree. I work as a journalist specialized in economy for a year or so, but I decided that it was not my thing. So after that, I quickly changed careers towards physical therapy. Yes, during my time as a physical therapist, I realized that there was a lot of bullshit. There was a lot of bullshit information out there, and I kind of chose to become a skeptical physio. And currently, I'm studying a master's on philosophy of science.
Okay. Yeah, so Diego has a good page called Skeptical Physio. Interesting lore of, I guess, the Nobullshitphysio. He's the one that told me to start a page. I think we were talking in the DMs about the nonsense in the field, and it kind of pushed me. And I guess now we.
When you were the Kiwi guy.
Yeah, you can't dox me like this. Yeah, we're gonna edit this out. All right. Today's going to be mostly a Diego-centric episode. Even I had jokes prepared. I'm going to keep that for the next episode because I'm the only one that prepares jokes. I have a little fun segment called the Influencers That Don't Exist, which I previewed last episode. But for this one, we're going to mostly do it seriously. It's about CranioSacral Therapy, which is something that's very popular in osteopathy. As far as I know, at least in Canada, I don't think this is taught in physio school. Is it in Spain, Diego?
Yes and no, it depends on what curricula you are checking. But for example, I was taught certain concepts, which in part made me realize how much bullshit there was when it comes to CranioSacral therapy. But I can tell you that some programs in Spain are still teaching this because in Spain, osteopathy and chiropractic are still not considered like regulated professions. So they are touched as kind of branches of physical therapy. And that opens a lot of possibilities to introduce osteopathic and chiropractic concepts into the physical therapy.
Yeah. I mean, it's not like Canada's this magic wonderland of evidence-based science. The teacher at my school would teach visceral manipulation. She didn't teach it at school, but she was the one who gave us manual therapy classes did it, and she taught us how to palpate the sacrum and put it back in place. Which, if you know anything about the work of like Thalberg in 1998, we all know that's nonsense, and we should have known this for at least 20 years, I'd say. We've had conclusive evidence it's like too small of a movement to palpate with their hands as well. There's even a paper, I think, in 1990, not 1993, but there's a paper by Sells. I don't recall the exact year. It's like on cell phone. Basically, they looked at how sensitive the fingers were, and it like your finger can't discriminate. Like the touch discrimination, basically the difference, like the smallest distance you can discriminate between your finger is smaller than or it's in the same order basically as what the sacrum moves. So it would be the example I gave is it's like using a ruler that's in decimeters to measure movement that's in centimeters. It's so imprecise, it doesn't make sense. But regardless, today we're talking about craniosacral therapy. So I'm going to let you go off and start with your introduction. So,
of course,
what is craniosacral therapy? Yeah. Go ahead.
Okay, so the thing is, osteopathy has three pillars that sustain the whole profession. So these three branches are structural, craniosacral, and visceral osteopathy. We need to take into account that osteopathy was born in 1874 as a response to the standards of medical practice at the time, and that we now know as heroic medicine. And this medical paradigm was based on the theory of the four humors, which proposed that disease was the cause of an imbalance between four fluids of the body. those fluids being blood, yellow bile, black bile, and phlegm. So medical practitioners tried for centuries to restore balance to these fluids by exposing the patient to radical treatments that they had to endure if they wanted to survive. So this is when bloodletting appears. And as a curiosity, I can tell you that George Washington's death is a tribute to bloodletting after his physicians took like 2.4 liters of blood to save him from a throat infection. And after that, we can include also another methods used in heroic medicine like laxatives, ingesting mercury, sweetening as much as possible, or purging. We want to, or I would like to acknowledge that osteopathy was a better system than heroic medicine, not because the treatments had big positive effect sizes, but because they were being compared to treatments that had huge negative effects. So we have some data to suggest that certain individuals were aware of the dangers of heroic medicine and tried to change the paradigm by promoting other forms of treatments, like Hahnemann did with osteopathy, or even with research. Because in another curiosity, this was I found this anecdote in the paper in the book How to Read a Paper by Tricia Greenhalgh. So she said that in the 17th century there was a physician called Jan Battista van Helmont that became skeptical of bloodletting and proposed a clinical trial involving large numbers, randomization, and statistical analysis. So he proposed that he would take like 200 to 500 per people and divide them into two groups. So he will protect one group from phlebotomy while allowing the other one to be treated with as much bloodletting as his colleagues consider appropriate. And they will then measure the number of funerals in each group to assess the efficacy of bloodletting. And this was never carried out, so we don't really know what would have happened. So the thing with CranioSacral osteopathy is, while it is true that osteopathy was founded by Andrew Taylor Still in 1874, it was William Gardner Sutherland who created the craniosacral field back in the 1930s. His wife wrote a biography which was called With Thinking Fingers. She wrote that Sutherland was observing at school when he noticed that the cranial sutures resembled the gills of a fish, and he thought, okay, if they look similar, they may have similar functions. So he started to pay attention to the ability, the purported ability of the sutures to expand and contract, giving birth to what nowadays we call the primary respiratory movement, which a priori may seem to be possible in kids because their cranial sutures haven't fused yet, but even then, I admit that it's not plausible. That said, I started to read some of the literature on the matter of cranial fusing in animals and humans, and the truth is that there are some variations between individuals when it comes to when cranial sutures fuse. So while this doesn't change much of the usual criticisms, it's closer to the truth. So the thing is, Steele and Sutherland belong to a more theoretical role when it comes to craniosacral osteopathy. The osteopath that really developed the treatment system was John Aplager, with a number of studies, usually in the 70s. One of these studies, which was published in 1977, aimed to show that the diagnostic methods developed until that point had high intra and inter-reliability, but they ended up creating their swan of Damocles, which we'll talk about later.
All right, so I guess the next part is, whether cranial sutures really move. And I guess we're going to talk about it, but to me, the idea that's always been insane when I have these conversations with osteopaths is that even if like that magical rhythm exists, which is to me at face value very improbable, because I feel like I would have learned it in all my biology classes. Like you learn about the heartbeat and the circadian rhythm, or even like the biological clock, stuff like that. But it's like, yeah, we're just going to exclude this thing that, the organ, like the brain, the most interesting organ, we're just going to neglect that it has this magical rhythm. First of all, improbable. Second, even if it exists, like the idea that we can change the rhythm with our hands is kind of insane. It's like, with that logic, I could, like, oh, you have a fast heartbeat, I'm just going to massage it, and then now your heart, like, you no longer have high blood pressure. Like, it just doesn't make sense as face value, to me at least. So yeah, there's a lot of like logical leaps, and I think this is the one that we're going to explore now. Again, cranial sutures really move Diego.
Yeah, so what we have tried with this episode is to kind of debunk each of, let's say, the core premises of CranioSacral therapy. And in this case, I believe that the Gordian knot of this debate, when it comes to those who are in favor or against the CranioSacral field, is to what extent cranial sutures really move. Because if cranial sutures don't move, the premises and conclusions built by using that osteopathic axiom crumble. So, if we resort to basic biological principles, as you said before, it's true that there's a period of time when bones are fusing and have their endings made of cartilage to allow for musculoskeletal growth. But of course, since growth spurts differ between humans, it is expected that those bones will reach their final form between teenage years and the early 20s. Because I would like to be as correct as possible, I need to tell you that some papers have shown that indeed certain cranial sutures never fully fuse, as observed in some cadavers. But we expect that, of course, this variability is similar to the asymmetries or radiological findings that we find in asymptomatic people. So, to put it in a simple way, there are people for everything.
Yeah.
So,
Yeah. Can I just interject? I'd like to say that this idea that we, especially in the MSK field, where we use things that are true in children to extrapolate to adults is extremely common. So there's a lot of like hip mobility movements and like jaw movements, even like the whole mewing movement. I'd say a whole part, they think they can modify the, and again, the last big deep dive we did with Elliot was about specifically this. It's just they'll look at kids, and it's true that like breathing patterns and all that can influence the jaw. As a, you know, if you're a kid, you're more likely to have like crooked teeth if you breathe through your mouth. There is data to suggest that, but it's very unlikely that it's the case in adults because your bones are fused. You have like growth plates. They fuse when you're past like skeletal maturity, which happens between 18 to 25 in most people, except if you have like gigantism or something. And even then, I think maybe whatever. Point is, in most people, it does happen this way. So the idea that we can like change the shape of your hip or your jaw with like movement is quite improbable. It might happen in neglectable amounts, and it's just like I think people are just kind of chasing like a white dragon in a lot of cases. So I see a lot of people that have hip pain, and they try to increase the hip mobility, and they're like, I'm stretching my hips, but all they're doing is jamming their femoral bone into their, their socket, the femoral socket, because it's like the bone's not going to change shape. It's just going to hurt, and then eventually you're increasing your risk of developing like femoroacetabular impingement, or at least irritating that joint, because what you're feeling is not a stretch. You're feeling the bones, not exactly the bones, I guess, like the fiber cartilage jamming together, and that's not super pleasant, and it's probably not going to lengthen, because if it did, people that run would become extremely hypermobile in their ankles, right? They'd be like, their knees would be touching the floor when they're running at some point. If you run uphill, but they don't. It's pretty stable for a reason. It's made to absorb a lot of weight, like multiple increments of your body weight. So yeah, so again, I think craniosacral therapy fits right there. They took something that's true in kids. Kids are very, very malleable because again, when you come out as a kid, like the body, of course you have parents that are usually tailored to their environment, but sometimes let's say your parents are, I don't know, they're Asian. Let's talk about like when humans migrated from Asia, let's say to America, like way back. I couldn't tell you the year, but like when they crossed the Bering Strait. Like they were probably in a very different environment, and then their kid, when they gave birth, 9 months later, was probably in a very, very different environment. So maybe we evolved as humans, it seems, to have kids that are going to adapt to some degree past their genetics. So it's like, let's say you're a kid who, for some reason, you as a kid really, really need to run all the time, whereas your parents were sedentary. You're going to become good at running, and your joints are going to adapt to be good at running. We see that there's like this Grizzlack paper, I think from 2012, where like if you do powerlifting before you reach skeletal maturity, your cruciate ligament on average is going to be like twice as thick as someone who didn't. But that
I
only
think
happens
that
if you
there's
start
another
before.
paper like that on
Yeah.
skateboarders.
I don't think it was in skateboard. I think it was in skaters. It's
in skaters.
meta-analyses. It's very small. It's like a few percent difference. She's from Montreal. But yeah, the dominant leg, also in divers, I think, is the cruciate ligament is thicker. But in that one, they didn't control for age. So we don't know, but we do know that the ACL can adapt, but it seems to mostly happen either if you have a major injury where it can like regrow, or in kids, like before skeletal maturity. So again, it's that your body has kind of like a limited amount of adaptability. So maybe the sports that you do as a kid and the stuff that you do as a kid makes you good at doing those things to some degree. Obviously there's genetics, but the point is kind of adaptable. We see that for obesity as well. Like, if you're obese as a kid, it's much harder to stop being obese as an adult. Whereas if you just become obese as an adult, it's much easier to lose that weight because your baseline, I guess, that let's say at 12, at 18, it's like, okay, this is pretty much your baseline. And you could say that about psychology. It's kind of where you learn how the world works and how your body learns the world works. And it kind of adapts to some degree to that. Well, after 18, that's pretty much set. Not that we can't change, it's just much harder to change. So again, using kids to justify treatment in adults and saying it's going to work the same as kids, the same way we say, oh, baby, you should squat like a baby when a baby's head weighs like 50% of its body weight, doesn't really make sense. Okay.
Yeah.
Especially if you've ever stretched a baby, they have like basically no muscle tone. They can kick their head super easy. From what I've learned, is that true? You have a kid, so I know.
Think that at least they didn't use mice, so that's a step forward.
That's a good point. Yeah, that is a good point. But yeah, end of rant. Let's get back. I think you were telling me about
how to measure cranial suture movements.
Yeah, how to measure cranial suture movements.
Okay, so to measure these cranial suture movements, we need to use invasive procedures to reduce confounding variables, because we have seen that there are certain variables that may fool us. For example, breathing, movements of our body, or errors of measurement. So if we pay attention to the literature on the topic of cranial sutures, we'll see that the debate is not as clear as we would believe beforehand. So osteopath Viola Friedman conducted a study to answer this question back in 1971. She used a non-invasive instrument to measure these movements using a sample of adults, and she reported motions between 0.0127 and 0.0254 millimeters, becoming the first of a tradition of many papers that could suggest that these movements shouldn't even be measured in millimeters, but in micrometers. So the thing is, due to ethical reasons, of course, most invasive studies have been conducted on animals. So if we give a check, we'll start with the Heifetz et al. In 1991. So he measured cranial suture movements on beagles, the dog breed, and showed movements between 0.005 and 0.01 millimeters. We saw similar numbers again from Adams et al. In 1992. He chose cats as the sample, providing motions measured between 0.017 and 0.07 millimeters. And with that said, it's true that we should interpret these findings with caution, since animal studies do not need to correlate with studies carried on humans. That said, I think that the best study to answer this question was done by Hodov et al. In 1983, when he was able to avoid ethical restraints by conducting an invasive study on comatose adults. The results kind of align with what we could expect, because cranial suture motions were measured between 0.00078 and 0.0037 millimeters. So to the initial question that you asked me of does cranial sutures really move, the answer is yes, but these movements are measured in micrometers, which leads to the next question about if this movement exists, can we really even try to palpate them?
Yeah, that's a good question. My bias would be no.
Why do you think that?
All right, so I think this, and by the way, for the people that are listening to the audio, these are available on YouTube. We'll share the actual studies in the final edit. So we have an editor that adds the times we share the screen with all the resources if you want to find them. Okay, I guess the next question is like, if that's all true, like what are we really palpating? I've had a lot of osteopaths who are like, yeah, you can feel it. When you put your hands there, you can just feel it. But then I've also had conversations with people who do Reiki, and they say the same thing. And those who say they do quantum manual therapy, and I was like, what does that mean? Is that like a quantum field? And they just couldn't put into word what it meant. So I guess they're definitely feeling something. My question is, what is it? Is it all pareidolia? Which I think pareidolia is the phenomenon where we tend to want to basically identify structures where maybe there is none. It's just a natural way the human brain works, where we want structure maybe where it's not. So the classic example is seeing Jesus in a piece of bread. Man, it's just browning of bread that, if you brown 1 billion toast every day and there's 1 billion people that believe in Jesus,
yes,
at some point you're gonna find Jesus bread, And then, if you look at clouds, if you ask 10 people, they're all gonna see something different.
Yes.
And I
Animals.
guarantee you, if you ask like prepubescent teenagers, they'd see a discriminate amount like a disproportionate amount of penises in the sky. So it's like you see what you want to see sometimes. But yeah, so what are we really palpating, Diego, when we palpate
Okay,
these
so
things?
let's assume that we have passed the first criteria to keep allowing the possibility that CranioSacral therapy works. So CranioSacral sutures may move, even if it's just a few micrometers. I would like to put palpation skills in perspective by showing the width of common objects that we have at home. So in that sense, Alexis and me, we would like to encourage you to go to your kitchen and follow us on our experiment. So the first thing that we would like to compare is a grain of rice, which has a width of 3.1 millimeters. We would like you to grab one and add pressure to it because I'm sure that you can feel something even if it's not much. Now, after this, we would like you to try the same but with a single grain of salt. And we are saying, yes, a single grain of salt with an average width of 0.3 millimeters. Now, I think that even if you're a physical therapist, or osteopath, or a chiropractor, you are having some issues feeling it. A braille dot, which is used by blind people to read stuff, has a width of 1.44 millimeters, and we know how blind people develop their sense of touch better than to compensate for their lack of sight. So the question that I think starts to become a bit, let's say, inconvenient for osteopaths or those performing craniosacral therapy is, do you think that you could palpate a bacteria? Because I'm sure that you're thinking that I'm crazy for saying this, but listen, it has a size of 0.001 millimeters. And if you remember the conclusions from the Hidalgo paper, he showed that at most, cranial suture movement on humans are like on the scale of 0.0037 millimeters. So I think that that's something at least interesting. I would like to remark the observations made by von Heyman in 2003. The article was written in German initially, but has been translated, I believe, that someone affiliated with the Mackenzie diagnosis movement. So the article was titled "Was is the craniosacral rhythms?" And the conclusions were that, considering human physiology, movements and changes in positions can be perceived only when bigger than 0.07 millimeters. And this threshold is 20 to 30 times greater than what the active mobility of the skull can achieve. So again, we're still moving in the field of implausible explanations and improving claims. We would like to kind of give alternative explanations to what's really happening. And in that sense, I believe that those practicing craniosacral therapy ensure that they can feel these movements that are far beyond the human palpatory threshold because they truly believe that they are doing it. And I have heard some osteopaths suggesting that they have refined their skill to a level, thanks to practice, that these movements can be perceived. But again, I think that the most likely explanation is that they are being tricked by involuntary head movements. Another key co-founder that researchers have discussed is breathing, even influencing some invasive studies, which, again, as I said before, are meant to kind of kill those and we also need to take into account that our scalp and our hair move when a therapist places hands there. So this is a valid criticism because you can feel cranial sutures moving, but in order to do that, you need to be able to remove the influence that those superficial tissues have. I think that another potential explanation is that they have been intrigued by their education, as I think Alexis and I were also, because this is kind of a common phenomenon within the musculoskeletal field to believe that we can perceive things that we cannot really perceive. And this is what we define as a shared phenomenological experience, which is a complicated way actually from philosophy to say that we can influence how others experience a given phenomenon. Funny enough, tell me, yeah.
Yeah, so I say anyone that's been in physio school can identify with that. So we had palpation classes where we were supposed to palpate which side the sacrum was nutating and if it was doing it properly. To be honest, the whole time I was like, I don't understand any of this. Like I don't feel it at all. I don't want to toot my own horn, but I think I've always been someone skeptical. So I was just like, yeah, I'm just going to fake it. And I passed with resounding colors, just pretending I knew the direction. But everyone was like, yeah, I'm feeling. I was like, yeah. In my head, I was like, okay, maybe I'm stupid. But turns out, yeah, that I was correct. Like again, the movements are too small to be palpated at this SI joint. So it's very, especially if you encourage a context where it's like, yeah, you're supposed to feel it, you're going to convince yourself that you're feeling. Like there's like mass psychogenic illnesses where people died. You know, there's this famous village in the Middle Ages and somewhere in Europe. I think probably was France. We're weird there.
Friends that they were dancing for weeks. Do
Yeah,
you
they
mean
just
that?
like so many people they danced to death because one person was like, "Oh, I can't stop dancing," and then everyone danced, and a lot of people just died from heat exhaustion or something.
Yes.
And it's just like, imagine, even at the cost of your life, like the group effect is strong enough to do that. And this has been expressed in the classic Another White Christmas. I'll share my screen to show that paper. So it is a classic paper where basically all they did is they played white noise. And they gave people a button. So it was a group of college students, if I recall. Yeah, undergraduate students. So a 2001 study by Merkelbach. I can just tell I'll put the reference here. Great paper. What they did is, again, they played white noise and then they had a button. And they told the student, at some point, another White Christmas by Bing Crosby, very popular song at the time, I guess, is going to be playing. When you hear it, push that button. And if I recall, a significant portion of the people pressed the button. So yeah, 32% of the sample pressed the button at least once. So about a third of people, and that's in a context where, again, one guy was like, yeah, there's something there, and there's basically no social consequence of not hearing it. But then we have people training in osteopathy and physiotherapy and probably in medicine as well, where we're like, yeah, you're supposed to see that. If you don't see it, you're a bad clinician. And you have the whole group who's like, yeah, I can feel it. And someone will do it and then you'll feel it. So again, there's a lot that could explain alternative explanations other than, yeah, that phenomenon actually exists. And then ask a kid if he's ever seen Santa Claus. That's another example. Although there's some trickery involved there, I'll say. Another explanation that could be there is the ideomotor principle. So the ideomotor phenomenon is a psychological phenomenon where a subject makes motions unconsciously. The classic example that's given is when you have, that divining rod, like the stick that's shaped like a Y, and you can find
Water?
Sources of water. You might have seen this in cartoons as a kid.
Yeah.
So the idea is you have unconscious movements and then it leads you to water, but it's just there's probably other things that are leading you to water. So maybe there's the grass is greener around there, so the grass grows better because there's water under. But you're like, no, it's the stick that told me. It's just, no, you're just noticing things that your brain is not consciously noticing, and that's guiding the movement unconsciously. Another
Do you know
example,
the story of James Randi in Australia with that
is that
same
the
style?
guy he pretends to find cadavers?
No. In this case, there were a group of people that say that they could know where water was located in Australia by using those sticks. We call them
Okay, so he was
Thauri.
a water diviner. Okay, and then
Yeah.
what about him?
And James Randi, I think that he brought someone who has geographical knowledge of the areas and said, look, there's water in this place, but I'm not going to tell you where, and you're going to find it. And I think that everything was full of water, so they will always be right. Then they moved to another location, I think, where there was no water. And when they tried the same trick, but they were full of confidence due to the previous experiment, they tried to do it again and they couldn't find anything. And they kind of showed that they were in a place that was full of water, and that most of the times they located something, it was only because they were at places that had water underneath, that they had
Interesting.
no.
I'd also say another example of the ideomotor phenomenon is police dogs. They're not really reliable, like the drug sniffing dogs. But apparently what police will do is that whether that's conscious or not, what they'll do is when they want that person, they suspect that person to be on drugs or to have drugs, they'll have body language that hints the dog to be like, oh yeah, I'm sniffing something. And then the police guy is happy because it's it confirms my bias, and then he pets the dog, and then the dog is happy because he did his job. So that makes it completely unreliable, but it might be completely happening unconsciously, because sometimes we have an idea, we want that idea to be true, and our body's going to move in unpredictable way. And if you don't believe that, tell me no one's ever told you why do you look pissed when you're pissed and you don't want them to know that you're pissed. It happens all the time. We have involuntary movements whether you want it or not. You've yawned in public and stuff like that. And we do that probably at a microscopic level where we're like, it is moving. It's like, no, it's probably it might just be your fingers moving on their own. Especially if, again, you insert that belief that's rewarding if it's true, because it makes you feel like basically a magician with your hands. So, yeah. I think I caught you off when you were talking. Actually, I don't know where we were where we were.
No, we're talking about how
yeah.
during lab practices we are shown how to palpate different structures and how those structures feels, and as you will say that it's a very common experience within the musculoskeletal field.
Yeah. Okay. Yeah, that makes sense. I guess the next part would be to talk about the problems with intra-rater and inter-rater reliability. Are you going to go into what that is? I think you are. Yes, you will.
Yes.
Okay,
yes,
so
yes.
yeah, Diego, tell us about that.
Okay, so we kind of have explored two of the core premises. The first one being, do cranial sutures move? Which the answer was kind of. The second part was like asking, okay, even if they move, how much and can we really perceive? Here the answer was no, like clearly no. Even if you claim to be an expert and have practiced the 10,000 hours that are required, even if those 10,000 hours are a myth. So we start with the next part, and in this part, I think that we reach another one of the criteria that are required to say that something is real and not an imagination. So it's the problem with intra-rater and inter-rater reliability. So of course, when we learn the art of and science of medical diagnosis, we're introduced to the concept of uncertainty. And we know that human tests are prone to fail for most diseases because the human body is a very complex biological environment. This is nothing new. Rater reliability is key because it represents the extent to which the data collected during the diagnosis process is accurate or is an accurate representation of the variables measured. If we follow on from this point, we have two constructs that we need to understand to better explore this topic. So, intra-rater reliability shows how much I agree with myself as an individual when I perform the same test several times. In order to kind of teach you this concept, I want you to imagine that I measure the height of an athlete with my hands and then I write the result. If I had a high intra-rater reliability, I will expect a measurement error of around 1 centimeter. But now let's say that the athlete is 20 years old and has finished his growth spurt. Now we can agree that his height is probably the same, but if my measurements show a range that go from 170 centimeters to 190, the measurement tool I'm using has a really low inter-rater reliability. And inter-rater reliability is kind of similar in the sense that it follows the exact same logic, but it is applied to several testers. Now let's say that I have a team of 10 physical therapists measuring the height of the same athlete, and the results show a measurement error of 30 centimeters. We will talk about a low inter-rater reliability. And now I would like to use this knowledge to understand why CranioSacral diagnosis is not reliable. So this is kind of an anecdote, but it shows a lot of the problems with CranioSacral therapy. And it's, as I said before in the introduction, John Ablayer is considered the father of the CranioSacral therapy part, while Sutherland is considered the father of the theories behind it. So Ablayer went in 1977 to a kindergartner along with some of his students to test the reliability hypothesis. So he chose 25 kids between 3 and 5 years old as the sample size. They tried to diagnose craniosacral dysfunctions by palpating craniosacral sutures in order to detect alterations in the primary respiratory movement. And here's where we enter into the controversy, because according to Ablayer, all kids had cranial movement restrictions in several parameters, yet they were fine. And I think that this study has never been replicated, at least as far as I know. But it is clear that if no one is classified as normal despite having no known health issues, maybe what is abnormal is the test. And I have added a table that I hope that you can share, because I think it's quite self-explanatory.
Yeah, let me just share the...
Of course.
Hang on. Yeah.
While you are doing that, I would like to tell you that the point scale was from 1 to 3, with 1 meaning no restriction and 3 meaning severe restrictions.
Okay, let me share it here. So this is the table.
Yes.
I don't know if y'all can see. So can you walk me through this table?
Of course. So let me open it too so I can see it better. Okay. So To the left side, we have the number of the subject. They did it to hide the identity, and they are like chosen in the order where they were
Yeah.
tested. Then we have they have written physician, but in reality is up ledger, and one
Yeah.
of his, let's say, students, because they were the ones trying to measure
Yeah.
when they kind of agreed upon the issue. And then the parameter number, what that's telling is which suture or anatomical location they were
Yeah.
testing. So if you find a number 1,
Yeah.
that means that there's no restriction. Everything beyond that is pathological. So in that sense, you will see that all the 25 subjects have at least one restriction. And one of the things that is common across osteopathy is that whether you are talking about visceral, craniosacral, or structural osteopathy, each of these branches say that even if you don't have health issues at the moment where you are diagnosed these restrictions, you will have them in the future, or at least if they happen, they will be justified by kind of these restrictions or
Yeah.
malpositions.
Yeah. Which I think a lot of osteopaths find that kind of romantic. I think there's an old saying that it says like osteopathy is finding a solution you don't understand to a problem you didn't know you had,
Mm-hmm.
or something like that, which I think is, it's like, haha, that's funny, but it's also like super harmful if you think about it, because it's just pathologizing normality. It's like, oh, you have blue eyes, that's actually horrible for you. Which, I
You will
mean,
pay
to be
for it
honest, it
later.
sounds, yeah, it sounds really dumb, but technically it's like it has way more truth than a lot of like osteopathy findings,
Mm-hmm.
because like blue eyes make you more vulnerable to the sun.
Yes.
Like, but like having a 1 centimeter, like 1 millimeter suture change, or like a like discrepancy, it doesn't mean anything as far as the data is concerned. So, if the joke is more logical than reality, I think as a profession, and again, I'm not saying osteopathy can't help, and I think this is a good place to kind of emphasize that here. We're not saying osteopathy is nonsense. Even craniosacral therapy, which I think is nonsense personally, at least the theories behind it, technically could help people. We're just discussing the mechanisms, which often could be a mix of placebo, contextual effects, neurophysiological effects, which are all valid. They're part of the human experience. So I refer a lot of people in osteopathy. It's just sometimes I tell people to maybe take the narrative with a grain of salt, because it's even in physio, like the reasons we think people are getting better might not be the reasons why people actually get better. The important thing is that they get better. And also, I say the second most important is that you're not creating a dependency in the patient where you're always like, oh, and you need to be here to fix you. We need to make sure your sutures are in order or whatever. It's more about making the patient independent so they can pain manage or manage on their own, ideally, especially if that's something that they want, instead of just creating a return patient.
Yeah, and this happens a lot also with chiropractic. We see how chiropractors go when it comes to spinal maintenance, and they will
Yeah.
ask you to go once or twice per month, maybe, to have like your spine realigned or something like that. Explanation that goes in those terms. And I remember, like 2 or 3 years ago, I saw a post by a chiropractor. Like he was really proud that the kids of a patient were coming also, because he
Yeah.
said like, look, this father started coming here 20 years ago, and I have been performing spinal manipulations on him, and now he's bringing his kids to
Yeah.
kind of keep with the tradition 20 years later.
Yeah. Yeah, it can be awful. I think personally. Well, I think at best it's like a worst waste of money to do that much maintenance. Not saying again that chiropractic can help, and there's also physios that do maintenance programs. I think Shirley Sharman's a good proponent of it. She's like, we should, you should have like GP visits with the physio to make sure we're checking how you move, because like that's how you get injuries. Which, I mean, at least has maybe some more credibility, but there's a lot of problems with that idea as well. It's not like the FMS or anything like that. Like the functional movement screen has been great at preventing injuries. According to most papers, it does not predict injuries in the future, despite it being an assessment of the quality of movement. It brings to question like, what is quality of movement? But that's an unrelated topic. Just for the people at home that might not be too familiar with inter-rater reliability, I'll just give an example real quick, just to reinforce that. Tasting wine or like tasting food in general could be a good example. So like, like let's say you have a bottle of wine, or let's say like a meal. If you really like chicken biryani or something, and you have it every time, and you're like, yeah, this is good chicken biryani, you'll tend to agree with yourself. But if it's someone that has different taste, the inter-rater reliability would be poor because it's something that's very subjective. But subjectivity tends to be the same. You're your own person, basically. So one way for that is the reason it's relevant is just like for pain, for instance. I think inter-reliability for the assessment of pain, I think it's probably horrible. And that's something we figured out really early when we were assessing pain. Like, my 10 is probably very different from someone else's 10, and my 2 is probably very different from someone else's 2. But and again, it's not perfect, but if we look at pain ratings across patients, it tends to be pretty, at least intra-rater reliable, because people have the same subjective criteria most of the time, at least in like the periods of time that we see them. So just a little note about that. And also I wanted to talk about, we were talking about how much the sutures move. So we were talking about like, what is it, micrometers?
Yes.
So I was talking about finger 2-point discrimination precision. So Van Ness in 2008, and I'll share my screen to show it. Where is it? There we go. So this is a paper by Van Ness in 2008, revising 2-point discrimination assessment in normal aging and in patients with polyneuropathies. And it showed that our fingers have a 2-point discrimination precision of 4 to 8.5 millimeters for static objects versus 3.5 to 6.5 millimeters for moving objects. So this is like 100 times less precise than what the craniosacral sutures are supposed to be moving. So again, the idea that you can palpate them is completely insane, in my opinion, at least, and the opinion, I guess, the
scientific community as a whole.
I guess if you believe in numbers, and if you believe that 4.8 is bigger than 0.00037, then you agree with me. Otherwise, I don't know what to tell you. I think you wanted to talk about the green paper from 1999.
Yes. So kind of to close or to finish this chapter, I would like to say that Ablayer kind of reported a high reliability, but Green and his colleagues in 1999 recalculated the data showing a reliability of 0.57. And I think that it's important for us to take into account that the threshold to accept tests as reliable is beyond 0.75. So if we go back to the papers, and I created a table with the aim of showing all the papers that kind of try to explore this question, if we check these papers, we'll find that the range goes from minus 0.32, which is absolutely low, and one of the papers concludes something like, if you obtain absurd numbers, it's because you're measuring things that probably doesn't exist. And kind of the paper that showed the highest reliability was the Ablayer one with, as I said before, 0.57. So I think that we can conclude that the current testing procedures used to diagnose by craniosacral therapies are very unreliable at best.
Yeah, I'd agree with that. I guess, again, the next part would be to consider, like, even if, we could palpate these movements, we could see, okay, this is abnormal. Can we distort those sutures with our hands? Can we correct be it the suture, the angle, or we already talked about the incorrect, like, craniosacral rhythm, which, again, I think it's just at face value we can discard because it is an absurd idea. Otherwise, you wouldn't need a heart medication. You just massage the heart correctly.
Yeah, absolutely. You need many leaps of faith in that sense to prove that craniosacral therapy works. And I don't think that this should be taken as an insult. I think that this is just something that is logical. And I don't have anything against craniosacral therapists or osteopaths in that sense. I don't have any animosity towards them. I'm just trying to be honest with the evidence. Sometimes it benefits, let's say, a side or a faction of the musculoskeletal field, but we are usually just trying to show to fact check in that sense. So I believe that to answer this question, the issue when it comes to judging the truth behind CranioSacral therapy is to
Yeah.
what extent we can even move these cranial sutures. And as I said previously, this requires a leap of faith because we have said that sutures movement is far below the human palpatory threshold and the diagnostic tests are unreliable. So I think that in an attempt to, let's say, keep showing why these ideas are implausible, I would like to entertain this thought. So let's assume that everything to this point is true. CranioSacral therapists propose that they use minute forces that are not superior to 30 grams to produce these movements. So to test this claim, we could use both minute and huge forces to ensure the outcome. So because of course, if you say that you're achieving movement with, let's say, 30 grams, if we do the
Yeah.
same exact thing but using 10 kilograms of force, that movement
Yeah.
first it should exist and it should be huge.
Yeah. I think you mean
So
minute, right? I
minute,
think you mean
yeah,
minute, not minute. Yeah. Okay. Minute.
yeah,
Minute.
minute,
Yeah.
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 So the thing is that this research has been done because it has been answered in animal models in two ways. The first example is a Downey et al. Paper from 2006. And in this research, this group applied forces of 5, 10, 15, and 20 grams to 13 adult rabbits. And one of them also experienced forces between 100 and 10,000 grams. So the conclusion was that no movement could be detected until 500 grams of force were applied. And even then, the movement was 0.3 millimeters. The second study that I think it's interesting to take into account is the Loxen et al. 1999 paper, where they used 13.5 kilograms of force to achieve a 1 millimeter movement in normal rabbits. And now that we have in mind these results and that they use invasive instruments to resolve the issues with the skin and hair that we talked about before, I think that this whole thing becomes even less plausible. And if we take into account that we are talking about the skulls of rabbits, which are in fact smaller and less resilient than the skulls of humans, I think that again we are seeing how another core premises of CranioSacral therapies has been tested and refuted, and this happened more than 2 decades ago. It kind of points to the question of when will this start.
Yeah. It takes a long time for research to be applied, especially in fields that I guess are not as interested in research as more, I'd say, traditional fields, which is, I guess, an argument as to why we shouldn't keep, I think, osteopathy on the outskirts. So there was a push, at least in Quebec, to bring osteopathy as a university program, and a lot of like medical people were like hesitant. My argument is that it's going to happen regardless. We might have as well have some rules in it, and kind of limit how much misinformation is dispelled in school at the bottom up level, if that makes sense. You could see it as, and it's funny, on this podcast I often use metaphors regarding like drug use and the drug war. It's just people are going to have drugs regardless. You might as well educate them about it. The DARE program was a resounding failure, as we've seen in the US, where it was just like, never say no to drugs. You should say no to drugs. It's just saying that is not super useful. You should say no to misinformation. It's just saying that is not super useful. You should try to teach people good information, and then hopefully they make the right decision with it. And also critical thinking skills and how to discriminate between bullshit and accurate information. And I think that's a lot of like professions that are, again, legislated by universities or higher learning groups. And I guess like you could say at osteopathy school or higher learning, because it's a tough program. It's just a lot of it is not rooted in science. And I have a lot of colleagues that switch into education. They're doing a tremendous job. So I salute you guys. Nicolas. Actually, they're both named Nicolas, so that's pretty funny. 2 osteopaths that used to work in my clinic. I love you guys. Yeah. Nicolas Gosselin, Nicolas Duchemin in Montreal. But I guess we could talk about, it kind of relates to the fact that, interestingly, like sometime in the 1920s, as if like almost in tandem with craniosacral therapy's inception, a chiropractor and osteopath by the name of Major Desjarnais created sacro-occipital techniques, otherwise known as SOT. And SOT seemingly uses the same philosophical and practical framework as craniosacral therapy. One of the core tenets that SOT and CST share is that the bones of the skull can be moved to improve the overall health of the patient. SOT consists of performing osteopathic maneuvers in order to manipulate these cranial bones and sutures in hopes of improving cerebrospinal fluid circulation. So I guess it's the CSF rhythm I was talking about, that mythical waves of the ocean. This is how it's been explained to me by osteopaths. It's like it's moving. It's like feeling like, you put your head like in a seashell and you listen to the ocean. That's what you do with your hands. Yeah. It's supposed to be improve the health and endura and the overall mobility of cranial bones. The research regarding SOT is unsurprisingly sparse and of incredibly low methodological quality. For example, one 2012 study by Chapman and colleagues reports that a 32-year-old veteran with low back pain and piriformis syndrome, which was something we can't even agree whether it exists or not, because there's only 10% of the population or something, where the sciatic nerve goes through the piriformis muscle. So it's more related to, has the deep glutes syndrome now. And again, even then, it's like very rare from what we can gather. But anyway, so that 32-year-old veteran had low back pain and piriformis syndrome, so-called piriformis syndrome, and he experienced pain relief via SOT. What the study also says is, upon further examination, is that the same patient also received lumbar and sacral spinal manipulation with soft tissue massage to the associated musculature, home exercise recommendations, proprioceptive neuromuscular facilitation stretches, electric muscle stimulation, and acupressure point stimulation. With so many variables in the patient's treatment and no control group, no conclusion can be made from this study, but it perfectly exemplifies the state of SOT research. They're very common. A lot of like woo-woo science stuff will give a bunch of stuff. I've seen that in primitive reflex studies as well. I've seen I think her name is like Annette Verpillot, like posture or whatever. I asked her to send me the best study on primitive reflex teaching, because she said that she can treat ADHD with like shaking kids' heads in the right direction, because that replicates some of the reflexes we have as babies, and that ADHD is some misfiring of those reflexes or something like that. And I was like, send me the best paper on it. And it was like this. They gave kids these little tonic reflex maneuvers or something. I think it was like 30 minutes a few times a week or something. But and then they're like, oh yeah, their symptoms, like their grades went up. But they didn't mention that they also did physical activity, which is something that's been shown to help for ADHD. And they also gave them something like 12 hours of additional one-on-one tutoring. Like, I have ADHD. If you know anything about ADHD, it's that it's tough to concentrate, especially in a crowded environment like school. But it's not as bad when you're alone, especially when you have one-on-one tutoring. So it's like, it's insane that they make these studies get funding is actually crazy. It's very clearly biased to show that something works, and that is a good example. So be wary if you say, oh, a study works. Always ask, what study, what methodology, and can we actually answer the question that we're aiming to answer? In this case, the study that's been shown, so this is a part that Elliot wrote, like the other host of this podcast. I think that the answer is a resounding no. But yeah, let's go on to part 6. So if we assume that everything is true, Diego, like, what happens? What are the results like for CST? Like, does it work? Because we talked about the theory a lot. What about the actual clinical outcomes of craniosacral therapy?
Yes, and I think that, again, we have debunked many of the premises, but even if we assume that everything is true, we still can, let's say, compare the treatment to a sham. And if the treatment really works as intended, it should show clear benefits compared to the sham. So we have tried to dissect the many shortcomings of the CranioSacral therapy system. By now, the conclusion should be that it's far from the image it has promoted for decades, and it can be explained mostly with a neurophysiological model better, as Bialowski did in the past. So once again, we are going to pretend that every premise that has been refuted by the evidence is true, and that treatment should be better than a sham. Like the comparison, isn't it? So we need to have treatments that show positive effects compared to natural history, and we need to ensure that those effects cannot be explained in ways beyond the intervention. And sure, they can work due to different effects caused by that intervention, because, again, for example, with exercise, we don't really know, but we would like to kind of isolate and test those explanations to find if the intervention is working by the reasons that are supported by other reasons, or maybe by things that has nothing to do with the intervention itself. And I know that this may sound too good to be true, but you can prove them by comparing the suggested treatment against the sham, like Carnes et al. Did for infantile colic in 2023. What they did was they compared CranioSacral Therapy against light touch with an intent to heal on 66 infants. And yes, they used the light touch sense or the light touch statement because they are using like 30 grams of force. So they chose this 66 infant. And the funny thing is that the treatment group cried more than the control group, even if it was not significant.
Jesus. So so the treatment group was worse?
Yes.
That's crazy. Well, that makes sense. If you've ever had a baby in the clinic, I refuse babies in general because I'm not sure if there's any paper suggesting any clear benefits of manual therapy, in my opinion, at least for stuff that's not like mechanical. Like maybe a contracture stretching helps, but like when a baby just has pain, the baby's just squirming and crying. I'm not sure it's helping. So, and it's clearly not fun. So, my bias is that a hug from dad or mom is probably going to be as effective, but that is just me.
Sure.
Maybe I'm wrong, and I'm open to more papers coming out. But from my understanding of the paper you mentioned earlier, so the Bielowski papers, it's two papers. The 2006 paper, where he was like, it seems like most of the solid evidence we have on the mechanisms of manual therapy are non-mechanical. Whenever we look for a mechanical explanation for manual therapy, we fail tremendously. And then he said, let's look back in 10 years and see if that's changed. And in 2016, he was like, no, it hasn't changed. We have way more evidence that it's neurophysiological effects. So the effect of the interaction, maybe some changes in skin temperature, like basically the effect of human touch, but not anything mechanical changing. It seems more and more that we can conclusively say that's how manual therapy works. So an interaction of the nervous system and like basically psychological variables. Yeah, so I forgot where I was going there. So I think a lot of these mechanisms, especially contextual effects, are not present in kids. I don't think they understand what's going on. Like a baby, like they don't understand that, oh, I'm a therapist, I'm actually trying to make you better. I think for a kid, like an adult that really believes that, oh, my vertebra is like out of place, he's going to put it back in place or whatever, even though that's not necessarily what's happening. Or they just believe in neurophysiological effects and they're like, human touch feels good, so I'm just going to feel that. And I'm going to pay this expert to do it. You probably have more effects there. So I think in a kid it's probably less effective. And if he's crying, like I wouldn't have an adult cry on the table with from the stuff I'm doing with my hands. Hopefully, I don't think it's justified. And there's a review on YouTube if anyone wants to look it up. It's just check Nobullshitphysio, should manual therapy be painful? And there's essentially no evidence that it is better to do painful. So why would you go into pain except if you're a masochist?
I would like to.
Is it a masochist
add,
or you're a sadist?
yes, like I would like to add that the study by Carnes et al. They blinded the parents, so the kids were treated in an isolated room, and then the parents received the baby, but they don't know if they received the, let's say, control or experimental treatment. They just were asked to measure how much time they were crying.
Yeah. So I like that you cited this paper because that's a huge issue in the investigation of manual therapy in children. A lot of it will be like, let's say, does spinal manipulation help babies' colics? And then they'll have the way they selected the patients was just like patients that came to chiropractics to help with infant colics, which is, sometimes you're looking for something and it makes sense. You have empathy, you don't want your kid to suffer. The colics is something that's self-resolving, and your sample is only people that believe in chiropractics, essentially. And you're like, hey, do you believe that you paid $60 for nothing, or that you didn't? That you did it and it was a good investment. Most people will say, it was a good investment, and you could see it in like you've probably bought like an ugly shirt and you've worn it regardless because there's no return policy. You could see that this is like quite similar. This is a biased sample. So yeah, I also don't think like adults are maybe the best, like the most reliable people to say that their kids feel better, especially because kids lie a lot. Adults do as well. I'm not, all right. There's also there's actually a meta-analysis that came out. There's two that came out recently. There's a brand new, like a few months ago, the Amendolara 2023 systematic review. I'm going to share my screen here. Oops, sorry, I have the wrong one. Here it is. There we go. Okay. So this, is it the correct one? I think it's this one. Yeah. So effectiveness of osteopathic craniosacral techniques, a meta-analysis. So they had only RCTs employing CST for any clinical outcomes were included. And then only English studies. They use the PRISMA guidelines, which is how to properly do a systematic review and pre-register it. And they had multiple independent observers extracting the studies. The primary outcome was the effectiveness of CST for selected outcomes is applied to non-healthy adults or children and measured by standardized mean difference effect size. So they had 24 RCTs that were included in the final meta-analysis, so that met the criteria pre-established, with a total of 1,613 patients. When results were analyzed by primary outcome, no significant effects were found. So when secondary outcomes were included, results showed that only neonatal health, so like very young babies' health, structure, prediction interval, and pain and chronic somatic and prediction interval show reliable, statistically significant effect. However, wide prediction intervals and high bias limit real-world implications of this finding. So what that means, you might be saying, oh, well, actually, if you look at the secondary effects, pain is better. A reason why you shouldn't be reasoning this way is because a common tactic, especially in alternative health or shoddy health papers, like the strategy that they use is they will take usually a small underpowered study and they'll have multiple outcomes. And then they'll be like, oh, that one outcome out of 16 is positive, and that's the one they're going to be reporting. So they'll be looking at like, baby height, baby colics, baby pain, baby fat percentage, baby muscle mass or whatever. And then they'll just pick the one that does ring true, which is not super reliable because that's like me, if you're like, you let's say you have like a bunch of, you draw like what's it called? It's like me trying to predict a dice. If I do that enough times, at some point, I'm going to have, a correct result. If I say 6 all the time, at some point, a 6 is going to come up. Mm-hmm. And that's problematic because that's the one that's usually announced like, oh, it helps this. Whereas it's probably, it might just be a fluke, a statistical fluke, which statistically, it's hard to even call that a fluke because it is going to happen at some point, and it doesn't mean that is a real effect, or rather that it is reflective of real-world applications of this study, right? So that's problematic because, again, if you look at the thing that we're actually looking at, when you look at that, the primary outcome, there's no effect. But it's only when you look at secondary outcome measures, which, again, are usually padding warranting future research, or, again, if you have a glass half empty, the way I am, you're like a skeptical person, often are used to, kind of, it's like a consolation prize when you didn't actually find what you were looking for. And it is often going to be there because, again, if you have enough ones, one is going to pop up as positive, even though it probably isn't reflective of the real sample, or the real population, rather. So that's the 2023 paper by Amendolara. Let me open another one, the Ceballos Laitas systematic review from 2024. So this one is published in the Healthcare Basel. Is CranioSacral Therapy effective? A systematic review and meta-analysis. I just want to mention it had Edzard Ernst as a co-author, second author. That guy's an absolute legend. He's like a professor of alternative health. I couldn't tell you which college. Hang on. In the University of Exeter.
Okay. Yeah, Exeter, yeah.
And he's I'd say like it's funny because he's a professor of alternative medicine, but I've never seen someone so dedicated to debunking their own field.
Yeah, because he was an homeopathic doctor, I think.
He was really.
I think so. Let
I'm
me
pretty
check
sure
it.
he's an MD now
Yeah.
and a researcher. But yeah, a lot of it is him being skeptical. So like before Instagram, he was basically Instagram. He was the Midbuster. He was the Aaron Kubal, like I said the champagne version of Aaron Kubal. No offense to Aaron, we love you. But he actually publishes the stuff that he does instead of doing TikToks, which again I could say about myself. I'm just saying he goes beyond, and he was doing that when it was just blog posts, and I don't think he makes a lot of money doing that. His blogs have basically no advertising, so really just a guy who does it for the love of the game. Absolute menace. I'll just read the whole paper from like as is, like the abstract, because it is pretty simple. So the objectives. The aim of the study was to evaluate the clinical effectiveness of CST and the management of any conditions. Methods. So 2 independent reviewers searched a PubMed physiotherapy evidence database, Cochrane Library, Web of Science, and Osteopathic Medicine digital library databases in August 2023, and extracted data from randomized controlled trials evaluating the clinical effectiveness of CST. The Pedro scale and Cochrane risk of bias 2 tool were used to assess the potential risk of bias in included studies. And then they assessed the certainty of evidence. And then when they synthesized the data, 15 RCTs were included in the qualitative and 7 in the quantitative synthesis. For musculoskeletal disorders, the qualitative and quantitative synthesis suggested that CST produces no statistically significant or clinically relevant changes in pain and or disability impact in patients with headache disorders, neck pain, low back pain, pelvic girdle pain, or fibromyalgia. So for those confused about the difference between statistically significant and clinically relevant, you can have something that's statistically significant but irrelevant. So like if, let's say, everyone in the population makes 0.0000001 cent more, you wouldn't call that clinically relevant, but it is there. It is statistically significant. So it was neither. It was neither like big enough effect to be relevant, nor was it present frequently enough to be considered statistically significant. And then for non-musculoskeletal disorders, the qualitative and quantitative synthesis showed that CST was not effective for managing infant colic, preterm infants, cerebral palsy, or visual function deficits. So yeah, it doesn't make you not blind, unfortunately. Conclusions. The qualitative and quantitative synthesis of the evidence suggests that CST produces no benefits in any of the musculoskeletal or non-musculoskeletal conditions assessed. 2 RCTs suggested statistically significant benefits of CST in children. However, both studies are seriously flawed, and their findings are thus likely to be false positives. Yeah, and if you guys want more detail, Edzard Hearns actually reviewed these on his blog, so you should go look him up. What's the name of his blog again? Hang on, let me find it.
edzardernst.com.
Oh, is it? Okay, so
Yeah.
he's changed it. I thought it was called like Skeptical Science or something. Okay, so it's just Edzard Hearns. So go look him up. He explains, he has a lot of articles on CST. He basically looks at these papers in excruciating details. Maybe not excruciating. It's actually pretty easy reads, usually like a 5-minute read regarding these specific RCTs. For us, I think we're just going to go with an epilogue. And I mean, up to you, Diego. So I think you wanted to talk about, you called this section the death of craniosacral therapy.
Yes, and I believe that we talked previously about how most of these core premises of CranioSacral Therapy have been debunked for already 2 or 3 decades, even more sometimes. But even then, I think that more and more voices are trying to kind of unify to form a common front to deal with this matter. So in the year 2006, I think that what we know nowadays as craniosacral osteopathy started to crumble under these criticisms. The first one was Steve Hartman, which is a well-known osteopath, and he published an editorial advocating for abandoning its practice. And I'm going to cite him, quote unquote, because he said, "Until outcome studies show these techniques produce a direct and positive effect, they should be dropped from all academic curricula, and insurance should stop paying, and patients should invest their time, money, and health elsewhere." So the thing is that same year, a group of physical therapists did something similar when they rebelled against those materials being taught and practiced by physical therapists in the United States. The group, led by Timothy Flynn, published an editorial called CranioSacral Therapy and Professional Responsibility, where he will claim for the exact same thing that a Hartman asked. This time is, quote unquote, the time is past due for advocates to contribute well designed studies evaluating the efficacy of these techniques, prove that it works, or move on.
Yeah.
And I think
Dylan,
that,
the
yes.
editor, add like Dylan, add some bald eagles and very American noise and like a guy saying, "What the fuck is a kilometer?" in this part, okay? Because this is a pretty ballsy move by, I guess, my dad's side of the family. All right.
Okay, so another osteopath, Marco Gabuti, published in 2014 an editorial dealing with the same problem around craniosacral therapy, but this time within the osteopathic academic curricula. And he called this osteopathic decapitation, claiming why do we consider the head differently from the rest of the body. So what he said was evidence-informed practice of osteopathy and the level of critical reasoning we expect from our students are no longer compatible with Sutherland's cranial model. If we follow his path, in 2016, Francesco Ceritelli could publish another article on the same topic to conclude that a practitioner aware of the scientific literature for osteopathic craniosacral therapy would most likely associate its potential use with a red traffic light system. And I think that here we are reaching a very interesting point. So, in the year 2016, again, a group of researchers under the acronym Cortex, and I would like Alexis to pronounce this stuff because it's in French.
I'll even do the French accent. Collectif de recherche transdisciplinaire, esprit critique et science.
Exactly. So they publish systematic reviews focused on the reliability and effectiveness of craniosacral therapy, showing a lack of inter and intra reliability, as we previously said. And so, when it comes to interclass correlation coefficient and a lack of proven effectiveness, which we added in the table too, that we may show you right now. So this systematic review confirmed what many of us thought, because um, it led to craniosacral therapy becoming a forbidden technique under the judgment of the French Professional Physical Therapy Association. And lately, it has been given a red light in a traffic light system, as Francesco Torritelli said. It's a document called like the Table of Illusory Techniques.
It's the most French way to name things.
Yes.
Yeah. I will say France though has like selective bias, so they went really hard against this technique called ajima, which is it just wet cupping or is it just cupping?
I think that it's cupping, but I don't know.
I think some of it is wet cupping, where you make the person bleed with an incision first to kind of purge the bad blood, allegedly, which probably doesn't happen. It's like an Islamic version of cupping, basically. And it's just funny because it's very obvious. France has a huge problem with being Islamophobic.
Yes.
I think it has to do with they have a lot of illegal immigration from the countries that they colonized in North Africa. So there's a lot of like racism towards there. I guess the North Africans, so the Algerians, Moroccans, Tunisians are essentially they're whatever the Mexicans are to the States. So imagine Mexicans had a technique that was like, we put taco on your skin to make it better. Well, it's like the States would ban that first if there was not like an absolute attachment to freedom of speech. Well, that's kind of what they did in France. They were like, yeah, what can we ban first? And strangely, it happened to the technique brought about by the slightly brown people they don't like. Okay. And the soapbox. So it's good that they're doing the right thing. It's just unfortunate that it's informed by racism pretty clearly, the same way that the hijab ban. Is it an hijab or no? It's the burqa that they ban, I think.
I don't really know.
Pretty sure you can't have a burqa in public. At least you can in like public, like in public office and stuff like that. Burqa banned in France. Hang on. In 2011, it became illegal for anyone to cover their face in a public space. A measure seen as targeting Muslim burqas. Yeah. So obviously, it's just like we're doing that for safety, and it's just okay, for sure. I don't think they care when like a hot lady in bikini wears a mask. Knowing French people. Yeah, they literally invented le bal masqué. Like a masquerade, like a mask ball is literally a French invention, but now they care about being able to identify you. Sure.
Yes.
Okay. End of my soapbox. I have like one every episode. And this one was to shit on France, which I have a right to because that's where my family's from. Years ago. Decades ago. I don't even know them. They're not French. It's just French Canadian.
Half French.
Yeah, so I guess they did that. Do you have anything to add to that, Diego?
Yes, so I created a post talking about CranioSacral Therapy like some years ago, and I included a skull and a hand, like holding that skull, trying to make a reference to Shakespeare masterpiece Hamlet. And in that sense, the protagonist, which is Hamlet, holds the skull of Yorick and starts to muse about existing, and he pronounces this kind of universal and well-known quote of "to be or not to be," and
Yeah.
it continues like "to be or not to be." That is the question: whether it is nobler in the mind to suffer the slings and arrows of outrageous fortune, or to take arms against a sea of troubles and by opposing end them. And I believe that somehow craniosacral osteopathy has become Yorick's school decades ago, yet we still keep it trapped in our hands, and we have become the prisons of the voices of these people that we have seen that may wish to end our journey once and for all, because nowadays it seems like craniosacral osteopathy is suffering a slow death, and the arguments in its favor remain unproven, as we have shown previously. So I think that if their promoters, current promoters, cannot decide whether it should be or not to be, maybe others should take a hard decision to let this treatment rest in peace finally.
Yeah, I would agree with that. And if you're like, oh, my patients feel better when I do that, just do a suboccipital release. It's just where you put your hands in the suboccipital area of the skull, basically. Just like at the base of the skull, you put your fingers there, it's a little massage. Much more rational. I'm not saying it works. We don't have strong data to show it works, but you don't need to inject these ludicrous ideas in a patient anymore. You can just say, hey, a massage feels good. Human touch feels good. This might help your headache a little bit. Done.
Perfect.
You're now evidence-based.
Welcome to our family.
Yeah, welcome to the club. Yeah, and I think I'd like you to kind of talk about, I think you had if listeners want more, you wrote an entire article about the issues that are currently going on with osteopathy, because we don't want to act like we're anti-osteopathy, as I've mentioned before. Like I refer in osteopathy. It's just some of the narratives I think we're against, and I think you wrote a really good article about this because we want it to get better, because I think that is good if osteopathy is better. Patients are better off as well. And I think you wrote a really good article. I think, was it with Oliver Thompson?
Yes.
Yeah.
I wrote it was with Oliver Thompson and Andrew Macmillan. Both are osteopaths, lecturers on the UCO, and they are also PhDs. So I wrote this paper, which is titled "The Fallacy of Osteopathic Anatomical Possibilism." In that manuscript, we kind of criticize the obsession that osteopaths, but also the rest of the musculoskeletal field, has when it comes to anatomy, and the outrageous claims that, or the unproven relationships that we may try to confirm. And I think that craniosacral therapy is one great example of anatomical possibilism, and something that I think should give us some thoughts or some food for thought when it comes to how absurd these premises based on anatomy are.
Yeah. If you guys want the full text, I assume you can just DM Diego.
Yes,
or you
of
can
course.
DM me. Yeah, you can DM otherwise the podcast page, the Fact Check Podcast on Instagram. Yeah, I guess we'll sign out here because I don't have anything to add. This was a great episode on CranioSacral Therapy. If you guys have suggestions for any episodes, you can DM. This is going to be on YouTube, or you can DM me or check me out at Nobullshitphysio on all platforms. Again, I offer physical therapy in person in Montreal, and internationally, I provide injury consulting and pain coaching online, so telehealth, which you can find in the link in my bio on Instagram. But I'm on all platforms at Nobullshitphysio. Diego, where can people find you?
Sure, you can find me on Twitter, well, X, as Physioskeptical, but most of my activity is done on Instagram, where you can find me an skeptical physio. At this moment, I'm only performing or offering my services in person in Madrid, but I don't know. Keep tuned, so maybe I will start to do online things in a while.
Yeah,
Who
we'll keep
knows?
our eyes peeled. All right, thanks, guys. This was the Fact Check podcast. We upload weekly, so check us out next week. All right, I'm Alexis Léveillé.
Adios.
Adios. Bye.